Rheumatoid arthritis. The first case, a 42-year-old female presents with bilateral hand joint pain, morning stiffness, lasting more than 1 hour, and fatigue for 6 months. On examination, there is a swelling and tenderness in the MCP and PIP joints. The MCP and the PIP joints located in the fingers. MCP means metacarpophalangeal joint, and the PIP means proximal interphalangeal joint. So they connects generally to the proximal to middle phalanges, that is the hinge. Lab finding indicates increase in ESR, that is erythrocyte sedimentation rate, increase in CRP, positive rheumatoid factor, and anti-CCP antibodies. This all indicates the case of rheumatoid arthritis. I mentioned the abbreviations here for your reference. MCP joints, that is the metacarpophalangeal joints. PIP joints, proximal interphalangeal joints. Then ESR, erythrocyte sedimentation rate. CRP, C-reactive protein, and rheumatoid factor, RF. Anti-CCP antibodies means anti-cyclic citrulinated peptide antibodies. What does it indicate? It means that more progressive joint damage, erosive arthritis, and poor prognosis if the anti-CCP antibody is present. These are the findings in our case. The question is, what is most likely diagnosis? The diagnosis is rheumatoid arthritis because the lab investigation, positive rheumatoid factor and anti-CCP, these are the strong suggestions for the rheumatoid arthritis. And the pain in joints, morning stiffness, these are all indicates the rheumatoid arthritis. And bilateral hand joint pain, so symmetrical small joint involvement plus prolonged morning stiffness more than 1 hour and plus seropositivity, these all are indications for the rheumatoid arthritis. Second question, what is the first line drug for long term disease control? Now, as we discussed in the musculoskeletal block, DMARDS, DMARDs is the first line therapy for the arthritis, rheumatoid arthritis. What is a DMARD? DMARD stand for disease modifying anti rheumatic drug. Here, our target is to modify the disease, not just relieve the pain. So that's why it is called DMARDs, disease modifying anti rheumatic drug. These are the first line therapy. And from these DMARDs, or we can say conventional or traditional DMARDs, the first top drug is methotrexate. Methotrexate is also antimetabolites used in the cancer treatment, and methotrexate is also traditional DMARD, the first line therapy in rheumatoid arthritis. How it acts? It inhibits the dihydrofolate reductase and reduces the immune activation. Methotrexate via dihydrofolate reductase reduces the immune activation, and that's why the joint destruction, our target of therapy here, to reduce the joint destruction is the main therapy, main target. So these drugs act by reducing the immune activation. Now, okay, the methotrexate or all the disease modifying anti-rheumatic drug, these drug does not reduce the pain, and the main concern of patient in the rheumatoid arthritis is the pain, morning stiffness, how to manage it. And we know that the DMARDs, all the DMARDs, biological DMARDs, conventional, traditional DMARDs, they will take some time, 2 week, 4 week to activate. So what about the pain? We need to manage the patient pain, the first or primary symptom. So question number 3, what is the role of non-steroidal anti-inflammatory drugs and corticosteroids here? Patient's main symptoms is the pain. So non-steroidal anti-inflammatory drugs, they relieve the symptomatic relief, that is the pain or inflammation. And corticosteroids, anti-inflammatory agents. So it breeds the therapy, or we can say breeds therapy until DMARDs acts. Because as we know that this DMARDs will take 2 to 4 weeks to activate. So until we can give the patient corticosteroid to reduce the inflammation, to reduce the pain. And remember, they do not modify the disease progression, because in the rheumatic arthritis, the disease progression is our main concern. And that's why we need to focus on the disease progression, and disease progression only elevated by the DMARDs. So for the pain and inflammation, we can consider NSAIDs and corticosteroids. Name one biologic agent used in rheumatoid arthritis. Now, biologic agent means these are the monoclonal antibodies, and these are used in moderate to severe rheumatoid arthritis that are not responding to conventional DMARDs. Which are the conventional DMARDs? Methotrexate, leflunomide. These are the conventional DMARDs. If the conventional DMARDs not getting benefit, then we need to move towards the biologic, that is monoclonal antibodies. And examples are adalimumab, when the last name is MAB. MAB indicates for the monoclonal antibodies. Or etanercept, which is tumor necrosis factor alpha inhibitor, and these are the effective if the conventional DMARDs not getting therapeutic benefit. Question number 5. Why is folic acid given with methotrexate? As we know that the mechanism of methotrexate is responsible for they reduce the dihydrofolate reductase and thereby inhibit the folic acid. So there may be the deficiency of the folic acid, and to reduce the toxicity of the bone marrow suppression or mucositis, we need to add folic acid in the therapy of arthritis, rheumatoid arthritis, when we are using methotrexate. So folic acid will reduce the toxicity caused by methotrexate, because mechanism of methotrexate, they will reduce the dihydrofolate reductase and thereby there is decrease in the folic acid. So what is the treatment plan here? This is a treatment plan for the rheumatoid arthritis. The initial therapy, we need to go for methotrexate plus folic acid. Methotrexate is a conventional or traditional DMARD, disease modifying anti-rheumatic drug. We need to add folic acid to reduce the toxicity of bone marrow suppression. And we need to add or may not add corticosteroid, because the primary concern of the patient is the pain. So it's very important how we relieve the patient pain. So corticosteroids found to be useful in the inflammation in the joints. If an inadequate response, then we can add sulfasalazine and hydroxychloroquine. Now, sulfasalazine and hydroxychloroquine, these are also DMARDs. We can say conventional or traditional DMARDs. This is modifying anti-rheumatic drug category. Sulfasalazine and hydroxychloroquine. And moderate to severe disease, if in the mild cases or primary cases, if the patient not getting benefit from the conventional DMARDs, then we need to give biological or monoclonal antibodies that act by inhibiting the tumor necrosis factor inhibitor, interleukin 6 inhibitors, and obviously supportive therapy. We need to add non-steroidal anti-inflammatory drug for the pain and the physiotherapy to manage the pain. So this is the first case of the rheumatoid arthritis. Let us see the second case of the rheumatoid arthritis. A 30-year-old female with 3-year history, age is 30, 3-year history of rheumatoid arthritis, is planning a pregnancy. She is currently taking methotrexate, that is conventional DMARDs, ibuprofen, that is a non-steroidal anti-inflammatory drug to reduce the pain, and low-dose prednisolone, that is a corticosteroid, will take care of the inflammation. She asked about the medication safety before conception. Yes. So this is the case of medication safety during the pregnancy. The first question, which drug must be stopped before pregnancy and why? Means which drug is teratogenic, which drug amongst the conventional DMARDs is teratogenic in the pregnancy and must, not should, must be stopped before pregnancy and why? Methotrexate, obviously, the first line agent is teratogenic, which is folate antagonist and cause fetal malformation and abortion, and therefore must be stopped at least 3 months before the conception. Why 3 months before the conception? Because the methotrexate half-life, we need to wash out all the drug and their metabolites, if any, available in the body to avoid any malfunction, fatal malformation, and the abortion. So it must be stopped at least 3 months before conception because of the half-life. Half-life of the drug. We need to wash out all the drug from the patient's body. Okay, if the methotrexate is teratogenic, then which drug is safe amongst the conventional DMARDs? The question number 2, which drugs are relatively safe during pregnancy? So, okay, low dose corticosteroid, that is a prednisolone, to reduce the inflammation, hydroxychloroquine, the conventional DMARDs, sulfasalazine with the folic acid. These are commonly used in rheumatoid arthritis during the pregnancy. So, which conventional DMARDs is safe during pregnancy in the patient of the rheumatoid arthritis? So, hydroxychloroquine and sulfasalazine, these both are found safe profile as compared to methotrexate. And low dose corticosteroids, it's okay to reduce the pain. Yes. Question number 3. What is the concern with non-steroidal anti-inflammatory drugs in pregnancy? As we studied in the previous block, principle of disease, growth and development block, the drugs in pregnancy and the lactation, and we know that we should avoid the non-steroidal anti-inflammatory drug in the third trimester because it leads to premature closure of the ductus arteriosus, and that may be again additional risk of oligohydramnios. Oligohydramnios means it's an abnormally low amniotic fluid volume around the fetus, and that may leads to the abortion and risk to the fetal growth. So the non-steroidal anti-inflammatory drug, apart from the paracetamol, should be avoided in the third trimester of the pregnancy. Question number 4, identify a potential drug interaction with methotrexate. Yes. Uh, Now the patient is taking, suppose, on the therapy of methotrexate and ibuprofen, which is just most commonly prescribed medication. But the non-steroidal anti-inflammatory drugs, ibuprofen, will decrease the renal clearance of methotrexate. And as we know that if there is decrease in the renal clearance, where is the drug? Drug in the body. And repeated administration of the drug leads to a buildup of the drug into the body, and that may leads to toxicity, and toxicity of methotrexate is myelosuppression. So this is the best example of drug-drug interaction and which drug the safety profile in the pregnancy. So we need to take care of if there is any methotrexate, we need to give with the ibuprofen. There is any drug-drug interaction that leads to the toxicity. Question number 5. What is the preferred management plan in this patient now? Now, as the patient on the methotrexate, we need to stop methotrexate before 3 months to avoid teratogenic effect, and ask the patient to switch on hydroxychloroquine alone, or we can add sulfasalazine and continue low dose steroid if needed to relieve the pain. And we need to suggest the treatment plan, which are the safe drug during pregnancy. In the treatment of rheumatoid arthritis, the hydroxychloroquine, sulfasalazine, these are the most safest drug, and the low dose steroid, that is prednisolone. Avoid methotrexate and leflunomide because both are teratogenic. So these 4 drugs, hydroxychloroquine, sulfasalazine, methotrexate, and leflunomide, these are DMARDs, disease modifying anti-rheumatic drug. And cautions: non-steroidal anti-inflammatory drugs should be avoided in the late pregnancy, in the third trimester, to avoid the fatal abnormalities and the abortions. So this is about the rheumatoid arthritis. Now let us see the cases of osteoarthritis. The clinical case: a 65-year-old obese male, age is 65, and obese, complains of knee pain worsening with activity and relieved by rest, morning stiffness less than 30 minutes, X-ray shows joint space narrowing and osteophytes, When there is a joint space narrowing and osteophytes in the X-ray, these are indication of osteoarthritis. And the risk factor here, the age and the obesity. The question, what is the diagnosis? The diagnosis is osteoarthritis, degenerative joint disease with mechanical pain. How we diagnose the osteoarthritis? The joint space narrowing and osteophytes in the X-ray, obesity, age, and the knee pain worsening with the activity and relieved by the rest. These all indicates the osteoarthritis. What is the first line pharmacological treatment? The acetaminophen, paracetamol is the preferred initial drug due to safety profile. Now remember here the age is 65 year, and in the old age, to relieve the pain, we need to avoid non-steroidal anti-inflammatory drugs because these drugs will affect on the kidneys, the renal clearance. So the safe drug here is the paracetamol, or we can say acetaminophen. Here our target is pain. When we compare with the rheumatoid arthritis, in rheumatoid arthritis, there is an the disease modification, progression. But here there is no disease progression. Our target concern here is pain. So to relieve the pain, in older, the paracetamol, acetaminophen is the drug of choice, preferred initial drug due to safety. And why other drug we should avoid? Because the age and it affects on the kidney. Same next question. When are non-steroidal anti-inflammatory drugs are used? We will go to the NSAIDs, means ibuprofen, diclofenac, naproxen. When paracetamol is ineffective, but we need to take care of the gastrointestinal and cardiovascular risk with the non-steroidal anti-inflammatory drugs and in old age patient. We need to use lowest effective dose. What is the role of intra-articular corticosteroid? As we know that corticosteroids has the property of inflammation, anti-inflammation. So for acute attacks or acute exacerbations, we need to give corticosteroids, intra-articular injection. It provides the short-term relief, and due to intra-articular injection, the target site will be achieved and it will decrease the systemic adverse effect. Name a non-pharmacological interventions. Yes, obviously it will be helpful. The weight reduction, because in this case the patient is obese, and obese patient, high weight will bear the additional burden on the knees and it increase the pain, and stiffness and space narrowing. So weight reduction and exercise, these are the core management strategy for the osteoarthritis. And the treatment plan obviously includes non-pharmacological, the first line, the weight loss, physiotherapy, exercise. Pharmacological includes paracetamol or acetaminophen. Both are same. First line, use topical non-steroidal anti-inflammatory drugs. Topical diclofenac gel, diclofenac solutions are available, and they will reduce the systemic adverse effect. If not benefit by the topical cream, diclofenac cream, then use non-steroidal anti-inflammatory by oral route. Advanced option, if this therapy fails, go for intra-articular steroid injection, then hyaluronic acid injection in selected cases, because hyaluronic acid injection will effective in the and will helpful in the narrowing the joint space. And severe disease, no benefit all this pharma therapy, joint replacement surgery. So these are the plan for the osteoarthritis patient.